Next presentation is by Dr. Selva Rani, CTO PCI Challenges.
And my dear friends, I am going to present CTO PCI challenge. I am Dr. Selva Rani. So this is a 64-year female, diabetic, hypertensive, referred from other medical college for PCI. On examination, the patient was stable and cardiovascular examination is normal and the blood parameters are within normal limits except for the increased HbA1c, poor control of diabetes. And this patient had MI 3 or 4 months before and the ECG is not significantly showing any ST elevation, only ST depression is there in the V2. And going to the angiogram, left main is normal and there is a LAD total cut mid LAD and right coronary system normal. So it is a single vessel disease with a LAD total cut. So we wanted to proceed with the CTO PCI and we started with the regular approach with 0.014 wire with a balloon support. We failed in that because the scoring is 4 here. The end is blunt and there is no tortuosity, there is no calcification, but there is the lesion length. We want to find it out by giving dual injection. This is the standard approach for any CTO. So with this approach, we went ahead with the same wire. We could not negotiate. The proximal cap now pierced and the distal cap we are not able to find out. So this is what the wire got. Actually, it is not entering and even with the balloon support.
Which wire?
It is a Marinata workhorse wire. After that, we changed to Fielder XT. And then we changed to Gaia 2 wire. Yes, that is why we want to go for the double injection. The left, right side axis with the left femoral root, we showed the course of the thing. So the left system is filling with the collaterals and we could demonstrate the distance between the CTO segment and the retrogradely filling LAD. The dual injection is showing the segment. So after this, we further proceeded. It is more than 2 centimeter. So we negotiated and finally the wire keep on entering into the one of the small septal branch and the distal cap is not negotiated. This is through the antegrade route. So we escalated the wire and finally succeeded. So now the wire is entering into the LAD. So the dual injection through the right coronary artery showed the piercing of the distal cap. So then we proceeded with the balloon dilatation, 1.5 balloon only. After seeing the distal artery, which is less than 2 millimeter, it is not fit for stenting. So this is a final angiographic picture with wire and without wire, LIO-cranial view. So we deferred stenting. Even though the collaterals are filling the distal segment, we have not preferred a retrograde route. It is a simple antegrade route with only wire escalation. We succeeded, but unfortunately distal vessel is small, so hence we could not place a stent and this patient is doing well. This is a final. So these are all the some of the 7 steps we have to follow. First you have to see the CTO PCI, what is the indication, and then dual injection is important to know the course of the artery and use of that is micro catheter in suitable places. In our case, there was no need for use of micro catheter And there are 4 CTO crossing techniques. What I have told, anterior wire escalation, retrograde wire, and retrograde dissection and entry. And change in the equipments is very important. You need not keep on probing in the same with the same guide wire like that instruments. So we have to change it. And the center of excellence is also playing certain role. And every effort should be made to optimize the stent deployment, which was not in our case. So proximal cap, distal vessel collaterals length are needed to be demonstrated by dual injection. Wire escalation needed in the C2 PCI antegrade. Use microcatheter if needed. No regrets to defer stenting if the distal vessel is small. Chance of perforation to be kept in mind every time. And procedure time, dye and consumable usage. The exhaustion of the resources has to be kept in mind. In advanced centers, the success rate is around 85 to 90%. Try after 6 weeks if you fail, and you have to wait for 6 to 8 weeks. Bleeding and vascular complications to be kept in mind because of the lengthy procedure. Thank you.
Yeah. Very good case. What was the procedural time in such case?
And this came most, and then senior. After that, I went in. I succeeded it, and totally it took around 1 hour.
Yeah, and as there is a flush total occlusion, and the missing segment was more than 20
millimeter.
and there was no significant collaterals.
Yes.
So it is advisable to perform a CTO in such case, or just hand over to
Patient admitted for unstable angina, madam.
Okay.
Patient had ACS some 4 months back. Now
So in our
anginal
center,
pain.
we, if there is a recent ACS, we do antithrombotic, low molecular heparin or any antithrombotic prior to the procedure. So that also establishes some kind of flow. And then our procedure is
Yes, we gave for 5 days because it is unstable angina, post-infarction angina.
okay.
Thank you,
And last shoot, there is some proximal flap dissections. In the
Yes,
LAD.
1.5
so would you
balloon.
like to recheck before discharge or after 4 to 6 weeks? Clinical
Yes, madam,
assessment.
it is always better to recheck. And this patient we are following up, and after 3 months, 6 months, 1 year, for want of academic purpose, I want to do angiogram for this patient.
So,
Thank you,
ma'am,
madam.
such cases probably are ideal for drug-coated balloons. So, after doing, you feel that this artery can't be stented. Many times, injecting more nicorandil, more nitrates,
Yes.
the artery tends to grow. But if you feel in your case it didn't grow, I would have preferred,
Diffuse
I would have put
disease.
in a long drug-coated balloon.
Yes.
This would have
That,
helped
yes, madam.
that would have really
That is
helped
the
in
best
plaque
But
healing.
at that time it was not available
Maybe
in our
that
resource.
was, it's an old case
Yes,
probably.
yes. For less than 2 mm, it's better to go for TEP.
Yeah.
That results are good by literature.
And such patients, you correctly point out that perforation chances are very high.
Yes,
so
madam.
you should have a
Covered
CPR,
stent.
toolkit, the complications management
Yes,
plan
reversion.
be ready.
Protamine, everything we have to keep ready. Thank you very much for the opportunity. Thank you very much for patient listening. Thank you.